I'm about to ruin your confidence. These Nclex questions look impossible until you know the one thing nursing school never taught you. How to think when everything goes wrong at the same time. Let's dive in. Question 1. Advanced sepsis management. A client in the ICU developed septic shock despite receiving broad-spectrum antibiotics for 48 hours. Current vitals. Blood pressure 78/45 millimeters of mercury on norepinephrine 15 micrograms per minute. Heart rate 135 beats per minute. Temperature 101.8 degrees Fahrenheit. Lactate 4.2 millimoles per liter. Urine output has decreased to 15 milliliters per hour for the past 4 hours. What should the nurse anticipate as the priority intervention? 1. Increase norepinephrine to 20 micrograms per minute to improve blood pressure. 2. Administer furosemide 40 milligrams intravenous to stimulate urine production. 3. Begin continuous renal replacement therapy, CRRT, immediately. 4. Initiate vasopressin infusion and increase fluid resuscitation. The correct answer is 4. Initiate vasopressin infusion and increase fluid resuscitation. Rationale. This client shows signs of distributive shock with inadequate response to high-dose norepinephrine. Greater than 15 micrograms per minute indicates catecholamine resistance. Adding vasopressin helps restore vascular tone through different receptors, V1 versus alpha-1. And continued fluid resuscitation addresses the capillary leak, causing intravascular volume depletion despite total body fluid overload. Why are other options incorrect? Option 1. Increasing norepinephrine beyond 15 to 20 micrograms per minute provides diminishing returns and increases the risk of cardiac arrhythmias and peripheral ischemia. Adding a second vasopressor with a different mechanism is preferred. Option 2. Furosemide in shock worsens intravascular volume depletion and can precipitate complete renal shutdown. Loop diuretics are contraindicated in distributive shock with oliguria. Option 3. While continuous renal replacement therapy, CRRT, may eventually be needed, hemodynamic stabilization takes priority. Starting CRRT in unstable shock can worsen hypotension due to circuit volume and ultrafiltration. Clinique RN Test Day Tip. In septic shock, sequential vasopressor therapy follows a protocol. Norepinephrine is first line, followed by the addition of vasopressin at 15 plus micrograms per minute, and then epinephrine may be considered. Never use diuretics for oliguria in shock states. Question 2. Advanced stroke management. A client presents 2 hours after a sudden onset of left-sided weakness, facial droop, and speech difficulty. The National Institutes of Health stroke scale score is 18. CT shows no hemorrhage, and blood pressure is 185/110 millimeters of mercury. The client weighs 80 kilograms. Which intervention should the nurse anticipate first? 1. Administer alteplase 72 milligrams, 0.9 milligrams per kilogram, intravenously over 60 minutes. 2. Lower blood pressure to less than 140/90 millimeters of mercury with nicardipine drip. 3. Prepare for mechanical thrombectomy within 6 hours. 4. Give aspirin 325 milligrams and start heparin infusion. The correct answer is 1. Administer alteplase 72 milligrams, 0.9 milligrams per kilogram, IV, over 60 minutes. Rationale. This client meets the criteria for acute ischemic stroke within the therapeutic window. less than 3 to 4.5 hours. With NIHSS 18, severe stroke, no contraindications are mentioned, and a weight of 80 kilograms. The alteplase dose is 0.9 milligrams per kilogram, 72 milligrams total, with 10% given as a bolus and the remainder administered over 60 minutes, as per AHA guidelines. Why are other options incorrect? Option 2. Blood pressure should not be lowered before or during thrombolytic therapy unless greater than 220 over 120 millimeters of mercury, as cerebral perfusion pressure is needed to salvage penumbra tissue. Post-thrombolytic target is less than 180 over 105 millimeters of mercury. Option 3. While large vessel occlusion may benefit from thrombectomy, thrombolytics are first line when the patient meets criteria. Both treatments can be complementary, but alteplase shouldn't be delayed. Option 4. Antiplatelets and anticoagulants are contraindicated within 24 hours of thrombolytic therapy due to bleeding risk. These are used for non-thrombolytic stroke management. Clinique RN Test Day Tip: Acute stroke. Time is brain. Thrombolytics within 3 to 4.5 hours if no contraindications. Don't lower BP unless greater than 220 over 120 millimeters of mercury. Pre-thrombolytics. Every 15 minutes saved means 1 month of healthy life gained. Question 3. Complex diabetes management. A client with type 1 diabetes using an insulin pump develops nausea, vomiting, and abdominal pain. Blood glucose is 380 milligrams per deciliter, ketones are large, and the pump shows occlusion alarm. The client's last successful bolus was 6 hours ago. What should the nurse do first? 1. Clear the pump occlusion and resume normal pump therapy. 2. Discontinue the pump and administer long-acting insulin subcutaneously. 3. Give a rapid-acting insulin injection and start IV fluids immediately. 4. Reprogram the pump with a higher basal rate to catch up on missed insulin. The correct answer is 3. Give a rapid-acting insulin injection and start IV fluids immediately. Rationale: the pump malfunction has caused insulin deficiency, leading to diabetic ketoacidosis. Immediate subcutaneous rapid-acting insulin addresses the insulin deficit, while intravenous fluids begin treating dehydration. Pump troubleshooting can occur after addressing the acute metabolic emergency. Why are other options incorrect? Option 1. With active DKA, pump malfunction repair isn't the priority. Even if cleared, pump delivery may be unreliable, and DKA requires immediate insulin replacement, not delayed pump resumption. Option 2. Long-acting insulin has a delayed onset, 2 to 4 hours, and won't address acute insulin deficiency in DKA. Rapid-acting insulin is needed immediately for ketosis reversal. Option 4. Increasing basal rates won't compensate for 6 hours of missed insulin and doesn't address the underlying pump malfunction. This approach delays necessary acute treatment. Clinique RN Test Day Tip: insulin pump failures can cause DKA within 2 to 4 hours due to no long-acting insulin backup. Always have rapid-acting insulin available for pump users. Don't try to catch up with pumps. Treat the emergency first.
By the way, if you want to practice these same style questions, check out the Clinique RN Q-Bank. It's got everything you need to level up your prep. AI feedback system that explains every answer in plain English. Cat mode so you can train under real Nclex conditions. And a summary sheet to help you review and track your progress after every session. It's like having your own personal Nclex coach in your pocket. You can sign up for free using the Clinique RN link in the description and start practicing right after this video.
Question 4. Advanced obstetric emergency. A client at 35 weeks of gestation with severe preeclampsia is receiving magnesium sulfate 2 grams per hour. She suddenly reports severe epigastric pain and her reflexes are now absent. Vital signs. Blood pressure 180 over 120 millimeters of mercury. Respirations 8 per minute. Magnesium level 9.2 milligrams per deciliter. What should the nurse do immediately? 1. Continue magnesium and give calcium gluconate 1 gram IV push. 2. Stop magnesium infusion and administer calcium gluconate immediately. 3. Reduce magnesium to 1 gram per hour and increase monitoring frequency. 4. Prepare for emergency cesarean delivery due to HELLP syndrome. The correct answer is 2. Stop magnesium infusion and administer calcium gluconate immediately. Rationale. Magnesium level 9.2 milligrams per deciliter indicates severe toxicity. Therapeutic range 4 to 7 milligrams per deciliter. Absent reflexes and respiratory depression, 8 per minute, are signs of magnesium toxicity requiring immediate antidote. Calcium gluconate reverses magnesium's neuromuscular effects, and the infusion must be stopped to prevent further toxicity. Why are other options incorrect? Option 1. Continuing magnesium with toxicity signs could cause respiratory arrest and cardiac depression. The infusion must be stopped immediately before giving the antidote. Option 3. Reducing the dose doesn't address existing toxicity. With severe symptoms, absent reflexes, respiratory depression, complete discontinuation and antidote administration are required. Option 4. While epigastric pain can indicate HELLP syndrome, the immediate life-threatening condition is magnesium toxicity, causing respiratory failure. HELP evaluation comes after stabilizing the toxicity. Clinique RN Test Day Tip. Magnesium toxicity progression. Loss of reflexes, 7 to 10 milligrams per deciliter. Then respiratory depression, 10 to 13 milligrams per deciliter, and finally, cardiac arrest, greater than 13 milligrams per deciliter. Calcium gluconate is the antidote. Always stop the infusion first, then give the antidote. Question 5. Complex wound management. A client with a stage 4 pressure ulcer on the sacrum develops a sudden onset of fever, 102.8 degrees Fahrenheit. Increased wound drainage with foul odor, and new areas of blackened tissue around the wound edges. Lab results show white blood cell 18,000 per cubic millimeter and glucose 340 milligrams per deciliter. Client has diabetes. What should the nurse suspect, and what is the priority action? 1. Wound infection. Increased dressing change frequency and culture drainage. 2. Necrotizing fasciitis. Notify the surgeon immediately and prepare for emergency debridement. 3. Osteomyelitis. Obtain blood cultures and start broad-spectrum antibiotics. 4. Diabetic ketoacidosis. Check ketones and administer insulin per protocol. The correct answer is 2. Necrotizing fasciitis. Notify the surgeon immediately and prepare for emergency debridement. Rationale. The combination of systemic toxicity, fever, elevated white blood cell count, rapidly spreading tissue necrosis, blackened edges, and foul-smelling drainage suggests necrotizing fasciitis, a surgical emergency requiring immediate, aggressive debridement within hours to prevent death from overwhelming sepsis. Why are other options incorrect? Option 1. A simple wound infection doesn't typically cause rapidly spreading necrosis or severe systemic symptoms. This presentation suggests deep tissue involvement requiring surgical intervention, not just topical care. Option 3. While osteomyelitis is possible with deep pressure ulcers, the acute presentation with spreading necrosis and systemic toxicity suggests necrotizing soft tissue infection requiring emergency surgery. Option 4. While diabetes can worsen with infection, the primary problem is the life-threatening soft tissue infection. Glucose management is secondary to controlling the necrotizing process. Clinique RN Test Day Tip: necrotizing fasciitis is a surgical emergency. Mortality increases dramatically with each hour of delay. Key signs: rapid tissue death, severe pain disproportionate to appearance, systemic toxicity, and dishwater drainage. Question 6. Advanced cardiac pharmacology. A client with heart failure is taking metoprolol 100 mg bis in D, lisinopril 20 mg daily, and spironolactone 25 mg daily. Today's labs show potassium 5.8 milliequivalents per liter, creatinine 2.4 mg per deciliter, baseline 1.2, and BUN 45 mg per deciliter. The client reports feeling weak and nauseated. What should the nurse do first? 1. Hold all 3 medications and notify the healthcare provider immediately. 2. Hold only the spironolactone and angiotensin-converting enzyme inhibitor. Continue the beta blocker. 3. Obtain a 12-lead ECG and hold spironolactone and lisinopril. 4. Administer Kexalate 30 grams by mouth and recheck potassium in 6 hours. The correct answer is 3. Obtain a 12-lead ECG and hold spironolactone and lisinopril. Rationale: the client has hyperkalemia, 5.8 milliequivalents per liter, and acute kidney injury, likely from the combination of an angiotensin-converting enzyme inhibitor and an aldosterone antagonist. ECG assessment is crucial, as hyperkalemia can cause life-threatening arrhythmias. Both spironolactone and lisinopril contribute to hyperkalemia and should be held, while metoprolol can continue with monitoring. Why are other options incorrect? Option 1. While spironolactone and lisinopril should be held, metoprolol doesn't directly cause hyperkalemia, and stopping it abruptly in heart failure patients can cause rebound hypertension and decompensation. Option 2. Both spironolactone, aldosterone antagonist, and lisinopril, angiotensin-converting enzyme inhibitor, increase potassium retention and should be held together. Continuing either maintains hyperkalemia risk. Option 4. Kexalate may be needed, but ECG assessment takes priority to evaluate for cardiac effects of hyperkalemia. Treatment should be guided by ECG changes and symptom severity. Clinique RN Test Day Tip: angiotensin-converting enzyme inhibitors plus spironolactone means hyperkalemia risk, especially with kidney dysfunction. Always check the ECG for hyperkalemia signs: peaked T waves, widened QRS, or heart blocks. Cardiac effects determine the urgency of treatment. Question 7. Pediatric respiratory emergency. A 4-year-old child presents with inspiratory stridor, drooling, and refuses to lie down, preferring to sit upright, leaning forward. The temperature is 103.2 degrees Fahrenheit, and the child appears anxious but alert. The parent reports symptoms started suddenly 4 hours ago. What should the nurse do first? 1. Examine the throat with a tongue depressor to assess for obstruction. 2. Obtain a lateral neck X-ray to confirm the diagnosis. 3. Keep the child calm, administer oxygen, and notify anesthesia immediately. 4. Start 4 antibiotics and prepare for intubation in the emergency department. The correct answer is 3. Keep the child calm, administer oxygen, and notify anesthesia immediately. Rationale. This presentation strongly suggests acute epiglottitis, inspiratory stridor, drooling, can't swallow, tripod positioning, and acute onset with fever. The priority is maintaining airway patency while preparing for controlled intubation by experienced personnel, anesthesia, ENT, in the operating room if needed. Why are other options incorrect? Option 1. Never examine the throat in suspected epiglottitis, as this can precipitate complete airway obstruction. Any stimulation of the inflamed epiglottis can cause laryngospasm and respiratory arrest. Option 2. X-rays can be obtained if the child is stable, but airway management takes absolute priority. Moving an unstable child to radiology risks airway compromise away from resuscitation equipment. Option 4. While antibiotics will eventually be needed, airway management is the immediate priority. Intubation should be performed by the most experienced provider available, typically in the OR setting. Clinique RN Test Day Tip. Epiglottitis means airway emergency. Never examine the throat. The 4 Ds: drooling, dysphagia, distress, and dysphonia, muffled voice. Keep the child calm and get expert airway management immediately. Question 8. Complex liver failure. A client with end-stage liver disease develops confusion, asterixis, and an ammonia level of 185 micrograms per deciliter, normal less than 50. The client also has ascites and peripheral edema. Which intervention should the nurse anticipate first? 1. Administer lactulose 30 milliliters by mouth every 2 hours until bowel movement occurs. 2. Start protein restriction to 20 grams daily to reduce ammonia production. 3. Begin paracentesis to remove acidic fluid and reduce abdominal pressure. 4. Initiate hemodialysis to rapidly remove ammonia and other toxins. The correct answer is 1. Administer lactulose 30 milliliters by mouth every 2 hours until bowel movement occurs. Rationale. The client has hepatic encephalopathy, confusion, asterixis, elevated ammonia. Lactulose is a first-line treatment as it acidifies the colon, converting ammonia to ammonium, which can't be absorbed, and promotes elimination through the cathartic effect. The goal is 2 to 3 soft bowel movements daily. Why are other options incorrect? Option 2. While protein restriction was historically used, current guidelines recommend maintaining adequate protein 1.2 to 1.5 grams per kilogram to prevent muscle wasting. Severe restriction can worsen malnutrition and doesn't effectively control ammonia in most patients. Option 3. While ascites may need treatment, hepatic encephalopathy is the immediate, life-threatening complication. Paracentesis doesn't address ammonia levels and can worsen encephalopathy through protein and electrolyte losses. Option 4. Standard hemodialysis doesn't effectively remove ammonia. Specialized treatments like molecular adsorbent recirculating system, MARS, may be used in severe cases, but lactulose remains the first-line therapy. Clinique RN Test Day Tip. Hepatic encephalopathy treatment. Lactulose first, goal 2 to 3 soft stools per day, then rifaximin if needed. Avoid sedatives and protein restriction. Asterixis is a classic sign. Test by having the patient extend arms and dorsiflex hands. Question 9. Advanced pain management. A client with chronic pain has been taking oxycodone 80 milligrams every 12 hours for 6 months. After surgery, the client reports a pain level of 8 out of 10, despite receiving the usual dose plus morphine 4 milligrams intravenous every 4 hours. The client is alert but appears uncomfortable. What should the nurse understand about this situation? 1. The client is drug-seeking and should receive non-opioid alternatives. 2. Opioid tolerance requires higher doses to achieve the same analgesic effect. 3. The client has developed opioid-induced hyperalgesia and needs a dose reduction. 4. Addiction has developed and the client needs an immediate withdrawal protocol. The correct answer is 2. Opioid tolerance requires higher doses to achieve the same analgesic effect. Rationale. This client demonstrates opioid tolerance, a physiological adaptation requiring increasingly higher doses to achieve the same analgesic effect. Chronic opioid use leads to receptor downregulation and altered pain pathways. Post-surgical pain in opioid-tolerant patients often requires 25 to 100% higher doses than opioid-naive patients. Why are other options incorrect? Option 1. There's no evidence of drug-seeking behavior. The client has legitimate chronic pain with acute post-operative pain superimposed. Dismissing pain-intolerant patients leads to inadequate analgesia and poor outcomes. Option 3. Opioid-induced hyperalgesia causes increased sensitivity to pain, but this typically presents with diffuse pain sensitivity, not inadequate analgesia to specific painful stimuli. The clinical picture suggests tolerance. Option 4. Tolerance is not addiction. The client takes medication as prescribed for legitimate pain. Addiction involves compulsive use despite harm, loss of control, and continued use despite negative consequences. Clinique RN Test Day Tip: Opioid tolerance versus addiction. Tolerance is physiological, needs more drug for same effect. Addiction is behavioral, compulsive use despite harm. Tolerant patients need higher doses for adequate analgesia. Don't confuse this with drug seeking. Question 10. Advanced kidney injury. A client develops acute kidney injury with the following labs: creatinine 4.8 milligrams per deciliter, baseline 1.0, BUN 78 milligrams per deciliter, potassium 6.2 milliequivalents per liter, phosphorus 8.9 milligrams per deciliter, and urine output 200 milliliters in 24 hours. Which complication should the nurse monitor for most closely? 1. Metabolic acidosis with Kussmaul respirations. 2. Cardiac arrhythmias from hyperkalemia. 3. Seizures from uremic encephalopathy. 4. Pulmonary edema from fluid overload. The correct answer is 2. Cardiac arrhythmias from hyperkalemia. Rationale: hyperkalemia, 6.2 milliequivalents per liter, poses the most immediate life-threatening risk in acute kidney injury. Elevated potassium can cause fatal cardiac arrhythmias, including ventricular fibrillation, heart blocks, and asystole. ECG changes may include peaked T waves, prolonged PR interval, and widened QRS complex. Why are other options incorrect? Option 1. While metabolic acidosis occurs in AKI and can cause Kussmaul respirations, it develops more gradually and is less immediately life-threatening than severe hyperkalemia. Option 3. Uremic encephalopathy typically occurs with BUN greater than 100 to 150 milligrams per deciliter and develops over days to weeks. While concerning, it's less acutely dangerous than hyperkalemic cardiac effects. Option 4. Fluid overload is serious, but usually develops gradually. With only 200 milliliters of urine output in 24 hours, pulmonary edema is a concern, but hyperkalemia poses a more immediate cardiac arrest risk. Clinique RN Test Day Tip: AKI complications by urgency, hyperkalemia, minutes to cardiac arrest, greater than acidosis, hours, greater than fluid overload, hours to days, greater than uremia, days to weeks. Always address a potassium level greater than 6.0 milliequivalents per liter immediately with ECG monitoring and treatment. Question 11. Complex anticoagulation. A client on warfarin for atrial fibrillation, target INR 2.0 to 3.0, presents with INR 6.8 and reports coffee ground emesis and black tarry stools. Hemoglobin has dropped from 12.2 grams per deciliter to 8.9 grams per deciliter over 12 hours. What should the nurse anticipate as the priority intervention? 1. Administer vitamin K 10 milligrams intravenous and fresh frozen plasma. 2. Give protamine sulfate 50 milligrams intravenous push to reverse anticoagulation. 3. Hold warfarin and monitor INR every 6 hours until therapeutic. 4. Administer packed red blood cells and vitamin K orally. The correct answer is 1. Administer vitamin K 10 milligrams intravenous and fresh frozen plasma. Rationale: this client has life-threatening bleeding with severe INR elevation. IV vitamin K provides faster reversal than oral, onset 6 to 12 hours versus 24 to 48 hours. And fresh frozen plasma provides immediate clotting factor replacement. The GI bleeding with a significant hemoglobin drop requires urgent reversal. Why are other options incorrect? Option 2. Protamine sulfate reverses heparin, not warfarin. It does not affect vitamin K-dependent clotting factors and would be ineffective for warfarin-induced bleeding. Option 3. With active bleeding and severe INR elevation, simply holding warfarin and monitoring is inadequate. The patient needs active reversal agents to stop the ongoing blood loss. Option 4. While blood transfusion may be needed, oral vitamin K is too slow for life-threatening bleeding. IV administration is required for urgent situations, and fresh frozen plasma is needed for immediate clotting factor replacement. Clinique RN Test Day Tip: warfarin reversal. Minor bleeding means hold warfarin plus oral vitamin K. Major bleeding means IV vitamin K plus fresh frozen plasma. Life-threatening means add prothrombin complex concentrate if available. Protamine is for heparin, not warfarin. Question 12. Advanced respiratory mechanics. A mechanically ventilated client suddenly develops high peak airway pressures, 45 centimeters of water, low tidal volumes, and oxygen desaturation. The ventilator alarms are sounding, breath sounds are absent on the right side, and the trachea appears deviated to the left. What should the nurse do immediately? 1. Increase positive end expiratory pressure to 15 centimeters of water to improve oxygenation. 2. Suction the endotracheal tube to clear potential obstruction. 3. Prepare for immediate needle decompression of the right chest. 4. Disconnect the ventilator and begin manual bag ventilation. The correct answer is 3. Prepare for immediate needle decompression of the right chest. Rationale: this presentation indicates tension pneumothorax, absent breath sounds on affected side, tracheal deviation away from affected side, high airway pressures, and hemodynamic compromise. Needle decompression, 14-gauge needle in the second intercostal space, mid-clavicular line, provides immediate pressure relief before chest tube insertion. Why are other options incorrect? Option 1. Increasing positive end expiratory pressure would worsen tension pneumothorax by adding more positive pressure to the pleural space, potentially causing cardiovascular collapse from venous return impairment. Option 2. While ETT obstruction can cause high pressures, the unilateral breath sounds and tracheal deviation clearly indicate pneumothorax, not airway obstruction. Suctioning delays life-saving decompression. Option 4. Manual ventilation doesn't address the underlying tension pneumothorax and could worsen the condition by continuing positive pressure ventilation. Decompression must occur first. Clinique RN test day tip. Tension pneumothorax is a clinical diagnosis. Don't wait for X-ray. Classic triad: absent breath sounds, tracheal deviation away from affected side, and hemodynamic instability. Needle decompression saves lives in minutes. Question 13. Complex electrolyte management. A client with chronic kidney disease on dialysis presents with muscle weakness, paralysis, and an ECG showing flattened T waves and prominent U waves. Serum electrolyte levels show sodium, 138 milliequivalents per liter, potassium, 2.1 milliequivalents per liter, magnesium, 1.2 milligrams per deciliter, phosphorus, 7.8 milligrams per deciliter. What should the nurse do first? 1. Administer potassium chloride 40 milliequivalents per liter intravenously. Push immediately. 2. Give magnesium sulfate 2 grams intravenously, then potassium replacement. 3. Start continuous cardiac monitoring and give potassium orally. 4. Prepare for emergency hemodialysis to correct electrolyte imbalances. The correct answer is 2. Give magnesium sulfate 2 grams IV, then potassium replacement. Rationale: severe hypokalemia, 2.1 milliequivalents per liter, with concurrent hypomagnesemia, 1.2 milligrams per deciliter, normal 1.7 to 2.2, requires magnesium replacement first. Magnesium deficiency prevents effective potassium replacement because magnesium is required for proper cellular potassium uptake. The ECG changes confirm severe hypokalemia, requiring urgent correction. Why are other options incorrect? Option 1. IV potassium should never be given as a push dose due to cardiac arrest risk. Additionally, without correcting magnesium first, potassium replacement will be ineffective, as magnesium is required for cellular potassium retention. Option 3. While cardiac monitoring is appropriate, severe hypokalemia, K plus less than 2.5 milliequivalents per liter, typically requires intravenous replacement due to paralysis and cardiac effects. Oral replacement is too slow for this severity. Option 4. While dialysis patients have electrolyte abnormalities, the immediate priority is correcting life-threatening hypokalemia. Emergency dialysis isn't indicated when targeted replacement can correct the specific deficiency. Clinique RN test day tip. Remember, magnesium first. Hypokalemia won't correct without adequate magnesium. Never give IV potassium as a push dose. Always dilute and infuse slowly. Max 10 milliequivalents per hour via peripheral line, 20 milliequivalents per hour via central line. Question 14. Advanced neurological assessment. A client who sustained a traumatic brain injury 24 hours ago has been stable with a Glasgow Coma Scale, GCS, of 14. The nurse notes that the client now has a GCS of 10, with a sluggish pupillary response to light, and reports an increasing headache. Vital signs show blood pressure 168 over 92 millimeters of mercury, was 130 over 70, HR 58 beats per minute, was 88, and irregular respirations. What should the nurse do immediately? 1. Administer prescribed morphine 4 milligrams intravenous for headache pain. 2. Lower the head of the bed to improve cerebral perfusion pressure. 3. Hyperventilate the client to partial pressure of carbon dioxide in arterial blood, 30 to 35 millimeters of mercury, and notify neurosurgery. 4. Give mannitol 1 gram per kilogram intravenous bolus and prepare for intracranial pressure monitoring. The correct answer is 3. Hyperventilate the client to partial pressure of carbon dioxide in arterial blood, 30 to 35 millimeters of mercury, and notify neurosurgery. Rationale? This client is developing increased intracranial pressure, ICP, evidenced by decreasing GCS, pupillary changes, and Cushing's triad, hypertension, bradycardia, irregular respirations. Controlled hyperventilation causes cerebral vasoconstriction, temporarily reducing cerebral blood volume and ICP, while neurosurgical intervention is arranged. Why are other options incorrect? Option 1. Morphine can depress respiratory drive and potentially worsen ICP by causing hypercapnia. Pain management in increased ICP requires careful consideration, as sedatives can mask neurological changes. Option 2. Lowering the head of the bed impairs venous drainage and worsens ICP. The head of the bed should be elevated 30 degrees to promote venous outflow while maintaining cerebral perfusion. Option 4. While mannitol may be used for ICP management, controlled hyperventilation provides more immediate ICP reduction. Mannitol requires careful dosing and monitoring for rebound effects and should be used judiciously. Clinique RN Test Day Tip. Herniation signs means immediate hyperventilation to partial pressure of carbon dioxide in arterial blood, 30 to 35 millimeters of mercury. Temporary measure. Elevate head of bed 30 degrees, and emergent neurosurgical consultation. Hyperventilation buys time, but can only be used short-term due to ischemia risk. Question 15. Complex infection control. A client admitted with pneumonia develops a new rash, fever of 103.8 degrees Fahrenheit, and hypotension after receiving vancomycin. The infusion was running at 2 grams over 60 minutes. The client appears flushed and reports feeling hot and itchy. What should the nurse do first? 1. Stop the vancomycin immediately and administer epinephrine 1 to 1,000. 2. Slow the vancomycin infusion rate and give diphenhydramine 25 milligrams intravenous. 3. Continue vancomycin at the current rate and monitor for improvement. 4. Stop vancomycin, give a normal saline bolus, and notify the healthcare provider. The correct answer is 4. Stop vancomycin, give a normal saline bolus, and notify the healthcare provider. Rationale. This presentation suggests red man syndrome from rapid vancomycin infusion, causing histamine release with hypotension, flushing, and rash. While not a true allergy, it can be serious. Stopping the infusion, providing fluid resuscitation for hypotension, and notifying the provider of rate adjustment are appropriate first steps. Why are other options incorrect? Option 1. This isn't anaphylaxis, but histamine release from rapid infusion. Epinephrine isn't indicated for red man syndrome and could worsen the situation by causing additional cardiac stress in a hypotensive patient. Option 2. While slowing the rate is appropriate for future doses, the current reaction requires stopping the infusion completely and addressing the hypotension. Diphenhydramine alone doesn't address the hemodynamic instability. Option 3. Continuing the infusion would worsen the histamine reaction and hypotension. The symptoms indicate the need to stop the current infusion and reassess the administration protocol. Clinique RN test day tip: Red man syndrome versus anaphylaxis. Red man means rapid vancomycin infusion, histamine release, flushing/hypotension, not IgE mediated. Treatment: stop infusion, fluids, slow future infusions to 2+ hours. True vancomycin allergy is rare. Question 16. Advanced endocrine crisis. A client with type 2 diabetes presents with blood glucose 1,100 milligrams per deciliter, serum osmolality 380 milliosmoles per kilogram, and altered mental status, but no ketones in blood or urine. The client appears severely dehydrated with poor skin turgor and dry mucous membranes. What should the nurse anticipate as the first intervention? 1. Administer regular insulin 0.15 units per kilogram intravenous bolus, followed by continuous infusion. 2. Begin aggressive fluid resuscitation with 0.9% normal saline at 15 to 20 milliliters per kilogram per hour. 3. Give potassium chloride 40 milliequivalents in first liter of IV fluid immediately. 4. Start 0.45% normal saline infusion to slowly correct hyperosmolality. The correct answer is 2. Begin aggressive fluid resuscitation with 0.9% normal saline at 15 to 20 milliliters per kilogram per hour. Rationale: this client has hyperosmolar hyperglycemic state, HHS, which primarily requires fluid resuscitation before insulin. Unlike DKA, HHS patients are severely volume depleted, often 8 to 12 liter deficit, and need aggressive fluid replacement first. Normal saline restores intravascular volume and gradually reduces glucose through dilution and improved kidney perfusion. Why other options are incorrect. Option 1. While insulin will eventually be needed, giving insulin before adequate fluid resuscitation can cause cardiovascular collapse in severely dehydrated patients. Fluid replacement takes priority in HHS management. Option 3. Potassium replacement shouldn't begin until urine output is established and current potassium level is known. Many HHS patients are initially hyperkalemic despite total body depletion. Option 4. Hypotonic saline is used later in HHS management after hemodynamic stability is achieved. Initial resuscitation requires isotonic saline to restore circulation. Clinique RN test day tip: HHS versus DKA. HHS means higher glucose, less than 600, no ketones, severe dehydration, older patients. Treatment priority: fluids first, then insulin. DKA means moderate glucose, less than 600, ketones present, younger patients. Treatment: insulin and fluids simultaneously. Question 17. Advanced surgical complications. A client, 48 hours post-operative from bowel resection, develops a sudden onset of severe abdominal pain, nausea, vomiting, and abdominal distension. Bowel sounds are absent, and the client has not passed flatus or stool since surgery. Temperature is 101.4 degrees Fahrenheit, and white blood cell count is 16,000 per cubic millimeter. What should the nurse suspect, and what is the priority action? 1. Paralytic ileus. Insert a nasogastric tube and begin bowel rest. 2. Small bowel obstruction. Prepare for immediate return to surgery. 3. Anastomotic leak. Keep NPO and notify the surgeon immediately. 4. Normal postoperative course. Encourage ambulation and clear liquids. The correct answer is 3. Anastomotic leak. Keep NPO and notify the surgeon immediately. Rationale. The combination of severe abdominal pain, systemic signs of infection, fever, elevated white blood cells, and absent bowel function 48 hours postoperatively suggests anastomotic leak, a surgical emergency. The bowel connection has broken down, causing peritoneal contamination and sepsis, requiring immediate surgical intervention. Why are other options incorrect? Option 1. Paralytic ileus is common postoperatively, but doesn't typically cause severe pain, fever, or leukocytosis. Simple ileus usually resolves with conservative management and doesn't present with signs of infection. Option 2. While obstruction is possible, the fever and elevated WBC suggest infection/leak rather than mechanical obstruction. Small bowel obstruction alone wouldn't cause systemic infection signs. Option 4. This presentation is not indicative of normal postoperative recovery. Absent bowel sounds at 48 hours with fever and leukocytosis indicates serious complications requiring immediate evaluation. Clinique RN Test Day Tip. Postoperative bowel surgery complications, anastomotic leak, means fever plus severe pain plus leukocytosis requires emergency surgery. Paralytic ileus means distension without fever/infection signs, managed conservatively. Know the difference. It's life or death. Question 18. Complex psychiatric emergency. A client with bipolar disorder is brought to the emergency department by police after being found running in traffic, claiming to be Superman. The client is hyperverbal, hypersexual, grandiose, and has not slept for 4 days. Urine drug screen is negative. What should the nurse do first? 1. Administer haloperidol 5 mg intramuscular and place in physical restraints. 2. Provide a quiet, low-stimulation environment and assign one-to-one supervision. 3. Give lorazepam 2 mg PO and attempt verbal de-escalation techniques. 4. Place the client in an isolation room and restrict all visitors. The correct answer is 2. Provide a quiet, low-stimulation environment and assign one-to-one supervision. Rationale. This client is in a manic episode with significant psychosis and impaired judgment, running in traffic. Reducing environmental stimuli helps prevent escalation, and constant supervision ensures safety while avoiding the trauma of restraints. The goal is to create a therapeutic environment that promotes stabilization. Why are other options incorrect? Option 1. Physical restraints should be a last resort and can escalate agitation in manic patients. Starting with the least restrictive interventions is both therapeutic and legally required, unless immediate physical danger exists. Option 3. Oral medications may be refused by psychotic, manic patients, and benzodiazepines can occasionally cause paradoxical agitation in mania. Environmental interventions should be tried first. Option 4. Complete isolation can increase paranoia and agitation in manic patients. Therapeutic engagement with consistent staff is preferred over punitive isolation measures. Clinique RN Test Day Tip. Manic episodes require a low and slow approach. Low stimulation environment, slow movements, and consistent staff. Avoid overstimulation, restraints, unless imminent danger, and confrontation. Safety first, but use the least restrictive methods. Question 19. Advanced pediatric emergency. A 2-year-old child presents with a sudden onset of choking, drooling, and respiratory distress. The parent reports the child was playing with small toys and suddenly started coughing violently, then became quiet and appeared blue around the lips. The child is conscious, but unable to cry or speak. What should the nurse do immediately? 1. Perform back blows and chest thrusts for foreign body removal. 2. Attempt to visualize and remove the object with McGill forceps. 3. Provide high-flow oxygen and prepare for emergency cricothyrotomy. 4. Position the child supine and begin bag mask ventilation. The correct answer is 1. Perform back blows and chest thrusts for foreign body removal. Rationale: this child has a foreign body airway obstruction with severe/complete obstruction, unable to cry, cyanotic. For children older than 1 year, the sequence is 5 back blows followed by 5 chest thrusts, repeated until object is expelled or the child becomes unconscious. Why are other options incorrect? Option 2. Never perform blind finger sweeps or use instruments to retrieve objects, as this can push the object deeper into the airway. Only remove objects that are clearly visible. Option 3. Cricothyrotomy is not appropriate for children less than 8 to 10 years due to anatomical differences, small cricothyroid membrane. Needle cricothyrotomy or surgical airway would be the last resort after failed basic maneuvers. Option 4. Positive pressure ventilation can force a foreign body deeper into the airway. Mechanical removal attempts take priority when foreign body obstruction is suspected. Clinique RN Test Day Tip: Pediatric choking. Conscious child equals back blows plus chest thrusts. Unconscious equals CPR with chest compressions, may dislodge object. Never blind finger sweeps. For infants greater than 1 year, use back blows plus chest thrusts, but position differently. Question 20. Advanced fluid and electrolyte crisis. A client with syndrome of inappropriate antidiuretic hormone, SIADH, develops confusion, seizures, and coma. Serum sodium is 108 milliequivalents per liter. The client weighs 70 kilograms, and the symptoms began 6 hours ago. What should the nurse anticipate as the priority intervention? 1. Administer 3% hypertonic saline to raise sodium by 2 milliequivalents per liter per hour. 2. Begin normal saline infusion at 250 milliliters per hour to improve hydration. 3. Give furosemide 40 milligrams intravenous to promote free water elimination. 4. Restrict fluids to 500 milliliters per day and monitor neurological status. The correct answer is 1. Administer 3% hypertonic saline to raise sodium by 2 milliequivalents per liter per hour. Rationale: severe symptomatic hyponatremia, seizures, coma, with sodium less than 110 milliequivalents per liter requires immediate correction with hypertonic saline. The goal is to raise sodium by 1 to 2 milliequivalents per liter per hour for the first few hours to stop seizures. Then, slow correction to prevent osmotic demyelination syndrome. Why are other options incorrect? Option 2. Normal saline, 154 milliequivalents per liter sodium, is hypotonic relative to the patient's needs and may actually worsen hyponatremia in SIADH by providing more free water than sodium. Option 3. Furosemide can help with fluid management in SIADH, but doesn't provide the immediate sodium replacement needed for severe symptomatic hyponatremia with neurological complications. Option 4. While fluid restriction is part of SIADH management, severe symptomatic hyponatremia requires active correction first. Restriction alone won't rapidly correct life-threatening sodium levels. Clinique RN Test Day Tip: severe hyponatremia with seizures equals medical emergency needing hypertonic saline. Correct rapidly initially, 2 milliequivalents per liter per hour to stop seizures, then slowly 0.5 to 1 milliequivalents per liter per hour to prevent brain damage. Total correction is less than 10 to 12 milliequivalents per liter in 24 hours. Question 21. Complex trauma and shock. A motorcyclist arrives after a high-speed collision with multiple injuries. Primary survey shows patent airway, equal breath sounds, blood pressure 70/40 millimeters of mercury, heart rate 140 beats per minute, and the client is responsive only to pain. External bleeding is controlled. The pelvis appears unstable on gentle compression. What should the nurse anticipate as the priority intervention? 1. Initiate massive transfusion protocol and apply pelvic binder. 2. Obtain a CT scan of the head, chest, abdomen, and pelvis immediately. 3. Administer 2 liters of crystalloid fluid and reassess hemodynamics. 4. Prepare for emergency exploratory laparotomy within 30 minutes. The correct answer is 1. Initiate massive transfusion protocol and apply pelvic binder. Rationale: unstable pelvis with shock, blood pressure 70/40, heart rate 140, suggests massive hemorrhage from pelvic fracture. Pelvic binder reduces pelvic volume and controls venous bleeding, while massive transfusion protocol addresses coagulopathy and provides blood products for ongoing losses. Why are other options incorrect? Option 2. While imaging may be needed, hemodynamic instability requires immediate intervention. Don't scan unstable patients. Control bleeding first, then image when stable. Option 3. Crystalloid alone won't address ongoing blood loss and can worsen coagulopathy through dilution. Current guidelines emphasize early blood products over excessive crystalloid in hemorrhagic shock. Option 4. While abdominal bleeding is possible, the unstable pelvis is the most likely source of life-threatening hemorrhage. Pelvic stabilization should precede exploratory surgery unless clear abdominal source. Clinique RN Test Day Tip: trauma with shock. Control obvious bleeding sources first. Pelvic binder for unstable pelvis, then blood products over crystalloid. Massive transfusion protocol means a 1:1:1 ratio of packed RBCS, plasma, and platelets. Don't delay for imaging if unstable. Question 22. Advanced Oncology Emergency. A client receiving chemotherapy for leukemia develops fever 101.6 degrees Fahrenheit, rigors, and hypotension, blood pressure 85/50 millimeters of mercury. Current labs show white blood cells 800 per cubic millimeter with 20% neutrophils. The client appears ill but is alert and oriented. What should the nurse do first? 1. Obtain blood cultures from 2 sites and initiate neutropenic precautions. 2. Administer broad-spectrum antibiotics within 30 minutes of fever onset. 3. Place the client in reverse isolation and restrict all visitors. 4. Give acetaminophen 650 milligrams and increase IV fluid rate to 150 milliliters per hour. The correct answer is 2. Administer broad-spectrum antibiotics within 30 minutes of fever onset. Rationale. This client has neutropenic fever. Absolute neutrophil count equals 800 times 0.2 equals 160 per millimeter cubed. Severe neutropenia less than 500. With signs of sepsis, hypotension, rigors. Per IDSA guidelines, broad-spectrum antibiotics must be administered within 1 hour of presentation, ideally within 30 minutes, as neutropenic patients can progress to septic shock rapidly. Why are other options incorrect? Option 1. While blood cultures and precautions are important, they shouldn't delay antibiotic administration. In neutropenic fever, antibiotics take priority over diagnostic testing to prevent rapid progression to septic shock. Option 3. Reverse isolation is appropriate, but secondary to immediate antibiotic therapy. Environmental protection doesn't treat the current infection that could be fatal within hours. Option 4. Symptomatic treatment doesn't address the underlying infection. While fever reduction and fluid support are helpful, antibiotics are life-saving and must be given immediately. Clinique RN Test Day Tip. Neutropenic fever means an oncological emergency. Absolute neutrophil count less than 500 plus any fever means antibiotics within 1 hour. Goal, 30 minutes. Don't wait for culture results or obvious infection source. Empiric broad-spectrum coverage saves lives. Question 23. Advanced medication toxicity. A client taking digoxin, furosemide, and potassium chloride presents with nausea, visual changes, seeing yellow halos, and irregular heart rhythm. Digoxin level is 3.2 nanograms per milliliter, therapeutic 0.5 to 2.0. Potassium is 2.8 milliequivalents per liter, and magnesium is 1.4 milligrams per deciliter. Which intervention should the nurse anticipate first? 1. Administer digoxin immune fab, DigiFab, 6 vials IV immediately. 2. Give magnesium sulfate 2 grams IV, followed by potassium replacement. 3. Hold all medications and obtain a 12-lead ECG to assess rhythm. 4. Provide activated charcoal, 50 grams PO, to bind the remaining digoxin. The correct answer is 2. Give magnesium sulfate 2 grams IV, followed by potassium replacement. Rationale. Digoxin toxicity is exacerbated by hypokalemia and hypomagnesemia. Correcting magnesium first is essential because magnesium deficiency prevents effective potassium replacement. Visual symptoms and an elevated level confirm toxicity, but electrolyte correction may reduce toxicity without requiring an expensive antidote. Why are other options incorrect? Option 1. DigiFab is reserved for life-threatening toxicity, severe arrhythmias, hyperkalemia greater than 5.0 from NAK pump inhibition. Electrolyte correction should be tried first, unless the patient has unstable arrhythmias. Option 3. While ECG is important, the immediate priority is correcting the electrolyte abnormalities that worsen digoxin toxicity. Holding medications is appropriate, but doesn't actively treat the toxicity. Option 4. Activated charcoal is ineffective for digoxin toxicity and dangerous in a nauseated patient who could aspirate. Digoxin has a large volume of distribution, making charcoal ineffective. Clinique RN Test Day Tip. Digoxin toxicity plus hypokalemia means dangerous combination. Always correct magnesium first, required for potassium uptake, then potassium. Visual changes and GI symptoms are early signs. Watch for life-threatening arrhythmias requiring DigiFab. Question 24. Complex respiratory failure. A client with severe COPD exacerbation is on bi-level positive airway pressure, BiPAP, with settings inspiratory positive airway pressure 16 over EPAP 6, fraction of inspired oxygen 40%. ABG results show pH 7.22, partial pressure of carbon dioxide in arterial blood 78 millimeters of mercury, HCO3 28 milliequivalents per liter, PaO2 55 millimeters of mercury. The client appears fatigued and is using accessory muscles. What should the nurse anticipate? 1. Increase inspiratory positive airway pressure to 20 centimeters of water to improve ventilation and CO2 elimination. 2. Increase the fraction of inspired oxygen to 60% to improve oxygenation immediately. 3. Prepare for endotracheal intubation and mechanical ventilation. 4. Switch to continuous positive airway pressure, CPAP, at 10 centimeters of water. The correct answer is 3. Prepare for endotracheal intubation and mechanical ventilation. Rationale. Despite BiPAP therapy, the client has severe respiratory acidosis, pH 7.22, partial pressure of carbon dioxide in arterial blood 78, inadequate oxygenation, and clinical signs of respiratory fatigue. These findings suggest impending respiratory failure requiring intubation and mechanical ventilation for full respiratory support. Why are other options incorrect? Option 1. While increasing IPAP might help, the patient is already showing signs of fatigue and may not be able to trigger the ventilator effectively. The severe acidosis suggests the need for full mechanical support. Option 2. Increasing FiO2 above 40% in COPD patients risks suppressing hypoxic drive. The primary problem is ventilation, CO2 retention, not just oxygenation. Option 4. CPAP only provides expiratory pressure support and won't help with CO2 elimination or reduce the work of breathing as much as BiPAP. Switching to less support would worsen the situation. Clinique RN Test Day Tip: BiPAP failure indicators: worsening acidosis, fatigue, inability to maintain settings, altered mental status. pH less than 7.25 with rising CO2 despite optimal BiPAP often requires intubation. Don't delay when patients are tiring. Question 25. Advanced burn critical care. A client with 45% total body surface area burns, deep partial and full thickness, is admitted 4 hours post-injury. Using the Parkland formula, the client should receive 14,400 milliliters of lactated ringers in the first 24 hours. How much should the client receive in the first 8 hours? And what assessment finding would indicate inadequate resuscitation? 1. 7,200 milliliters. Urine output less than 0.5 milliliters per kilogram per hour for 2 consecutive hours. 2. 3,600 milliliters. Blood pressure less than 90 over 60 millimeters of mercury despite fluid administration. 3. 14,400 milliliters. Heart rate greater than 120 beats per minute with weak peripheral pulses. 4. 7,200 milliliters. Central venous pressure less than 8 millimeters of mercury with normal heart rate. The correct answer is 1. 7,200 milliliters. Urine output less than 0.5 milliliters per kilogram per hour for 2 consecutive hours. Rationale. Parkland formula gives half the calculated volume, 7,200 milliliters, in the first 8 hours post-burn, then the remaining half over the next 16 hours. Urine output is the most reliable indicator of adequate resuscitation in burns. The goal is 0.5 to 1.0 milliliters per kilogram per hour. 2 hours of inadequate urine output indicate the need for increased fluid rate. Why are other options incorrect? Option 2. Blood pressure is maintained by compensatory mechanisms in early burn shock and is not a reliable indicator of adequate resuscitation. Urine output better reflects organ perfusion. Option 3. The total 24-hour volume shouldn't be given in 8 hours, which would cause fluid overload. Heart rate can be elevated from pain, stress, and hypermetabolism, not just hypovolemia. Option 4. CVP is not routinely used in burn resuscitation and can be misleading due to capillary leak. The 8-hour volume is correct, but CVP isn't the best assessment parameter. Clinique RN Test Day Tip. Parkland formula: 4 milliliters times weight in kilograms times percent burn equals 24-hour volume. Give half in first 8 hours from time of burn, not admission. Urine output is the gold standard for resuscitation adequacy in burns. Question 26. Complex maternal emergency. A client at 32 weeks of gestation with severe preeclampsia suddenly develops a severe headache, visual disturbances, and generalized tonic-clonic seizure lasting 90 seconds. Blood pressure is 180 over 120 millimeters of mercury. What should the nurse do immediately after the seizure ends? 1. Administer magnesium sulfate 4 to 6 grams intravenous loading dose over 15 to 20 minutes. 2. Give hydralazine 5 to 10 milligrams intravenous push to lower blood pressure immediately. 3. Position the client on the left side, assess the airway, and administer oxygen. 4. Prepare for emergency cesarean delivery due to eclampsia. The correct answer is 3. Position the client on the left side, assess the airway, and administer oxygen. Rationale. After an eclamptic seizure, the immediate priorities are ensuring airway patency, seizures can cause aspiration risk, positioning to optimize utero-placental blood flow, left side, and providing oxygen for both maternal and fetal well-being. This follows basic life support principles before medication administration. Why are other options incorrect? Option 1. While a magnesium sulfate loading dose is crucial for seizure prevention, airway assessment and positioning take priority immediately post-seizure. The magnesium should be started after ensuring basic life support needs. Option 2. Rapid blood pressure reduction post-seizure can compromise cerebral and utero-placental perfusion. Blood pressure management should be gradual and controlled, not immediate. Option 4. While delivery may be needed, immediate stabilization of the mother takes priority. Maternal stabilization before delivery improves outcomes for both mother and baby. Clinique RN Test Day Tip. Eclamptic seizure management. ABCs first: airway, breathing, circulation, then magnesium loading dose, then controlled BP reduction, then consider delivery. Never rush to deliver an unstable mother. Stabilize first. Question 27. Advanced infectious disease. A client with a central venous catheter develops fever, chills, and positive blood cultures growing methicillin-resistant Staphylococcus aureus, MRSA. The catheter has been in place for 12 days for chemotherapy administration. What should the nurse anticipate as the priority intervention? 1. Remove the central line immediately and send a tip for culture. 2. Start vancomycin 15 to 20 milligrams per kilogram intravenously every 12 hours through the line. 3. Begin antibiotic lock therapy with vancomycin in the catheter lumen. 4. Replace the catheter over a guide wire to maintain access. The correct answer is 1. Remove the central line immediately and send a tip for culture. Rationale: MRSA central line associated bloodstream infection, CLABSI, requires immediate catheter removal per IDSA guidelines. The catheter serves as a nidus for biofilm formation that antibiotics cannot penetrate effectively. Retaining infected catheters leads to treatment failure, complications, and death. Why are other options incorrect? Option 2. Treating through an infected catheter is inadequate for MRSA CLABSI. The biofilm protects bacteria from antibiotics, leading to persistent bacteremia, endocarditis, and other complications. Option 3. Antibiotic lock therapy is only appropriate for certain organisms, not MRSA, and specific circumstances, like tunnel infections without bloodstream involvement. MRSA CLABSI requires removal. Option 4. Guide wire exchange maintains the infected tract and is contraindicated in CLABSI. A new site must be used if continued access is needed. Clinique RN Test Day Tip: CLABSI management. Remove catheter for MRSA, Candida, and most gram-negatives. Some gram-positive organisms, coagulase-negative staph, may be treated through a catheter, but MRSA requires removal plus systemic antibiotics. Question 28. Advanced gastrointestinal emergency. A client with known esophageal varices presents with hematemesis, melena, and hypotension. BP 88 over 52 millimeters of mercury, HR 128 beats per minute. The client appears pale and diaphoretic. Hemoglobin has dropped from 9.2 grams per deciliter to 6.8 grams per deciliter over 2 hours. What should the nurse anticipate as the priority intervention? 1. Insert a large bore IV and begin octreotide infusion immediately. 2. Prepare for urgent upper endoscopy with varicose band ligation. 3. Administer packed red blood cells and fresh frozen plasma. 4. Insert the Sengstaken-Blakemore tube for tamponade. The correct answer is 1. Insert a large bore IV and begin octreotide infusion immediately. Rationale: active variceal bleeding with hemodynamic instability requires immediate octreotide, or vasopressin, to reduce portal pressure and splanchnic blood flow. Large bore IV access is essential for resuscitation. Octreotide decreases bleeding and facilitates subsequent interventions. Why are other options incorrect? Option 2. While endoscopic intervention is definitive, unstable patients need medical stabilization first. Octreotide helps control bleeding and stabilizes patients for endoscopy. Option 3. Blood products are important, but don't address the ongoing bleeding source. Octreotide helps stop the bleeding while blood products replace losses. Option 4. Balloon tamponade is reserved for massive bleeding uncontrolled by medical/endoscopic therapy due to high complication risk, aspiration, esophageal rupture. Try octreotide and endoscopy first. Clinique RN Test Day Tip: variceal bleeding sequence. Octreotide plus large bore IV, then endoscopy, balloon tamponade if needed, and finally, TIPS procedure for refractory cases. Start octreotide immediately. It reduces portal pressure and controls bleeding. Question 29. Complex pediatric cardiology. A 6-month-old infant with congenital heart disease suddenly becomes cyanotic, irritable, and demonstrates increased respiratory effort. The infant assumes a knee-chest position when placed upright. Oxygen saturation drops to 75% despite supplemental oxygen. What should the nurse suspect, and what is the priority intervention? 1. Congestive heart failure. Administer furosemide 1 mg per kilogram intravenously. 2. Hypercyanotic TET spell. Place infant in knee-chest position and give morphine. 3. Pneumonia with respiratory failure. Prepare for intubation. 4. Sepsis with distributive shock. Obtain blood cultures and start antibiotics. The correct answer is 2. Hypercyanotic TET spell, place infant in knee-chest position and give morphine. Rationale. This presentation describes a hypercyanotic episode, or TET spell, in tetralogy of Fallot. The knee-chest position increases systemic vascular resistance, improving pulmonary blood flow. Morphine reduces the infant's agitation and decreases oxygen consumption while increasing systemic vascular resistance. Why are other options incorrect? Option 1. While CHF is possible in congenital heart disease, the acute cyanosis and preferential positioning suggest TET spell rather than fluid overload. Diuretics wouldn't address the underlying right ventricular outflow obstruction. Option 3. The knee-chest positioning is pathognomonic for TET spells, not respiratory failure from pneumonia. This positioning is a compensatory mechanism specific to right-to-left shunting. Option 4. While infants can develop sepsis, the classic positioning and acute cyanosis in known congenital heart disease point to a hypercyanotic episode rather than infection. Clinique RN test day tip. TET spell management. Knee-chest position increases systemic vascular resistance, morphine reduces agitation or oxygen consumption, fluids if needed, avoid excessive oxygen, can worsen by decreasing pulmonary vascular resistance. Question 30. Advanced emergency toxicology. A client presents to the emergency department after ingesting an unknown amount of acetaminophen 6 hours ago. The client reports nausea, but appears stable. Serum acetaminophen level is 180 micrograms per milliliter, and liver function tests show AST 45 units per liter and ALT 52 units per liter, slightly elevated. What should the nurse anticipate as the priority intervention? 1. Administer activated charcoal 50 grams PO to prevent further absorption. 2. Begin N-acetylcysteine, NAC, loading dose 140 mg per kilogram by mouth immediately. 3. Monitor liver function tests and acetaminophen levels every 6 hours. 4. Prepare for hemodialysis to remove acetaminophen from circulation. The correct answer is 2. Begin N-acetylcysteine, NAC, loading dose 140 mg per kilogram by mouth immediately. Rationale. Acetaminophen level of 180 micrograms per milliliter at 6 hours post-ingestion is above the treatment nomogram line greater than 150 micrograms per milliliter at 4 hours, indicating risk of hepatotoxicity. NAC loading dose should be given immediately as it's most effective within 8 hours of ingestion, but beneficial up to 24 hours. Why are other options incorrect? Option 1. Activated charcoal is ineffective greater than 2 to 4 hours post-ingestion as acetaminophen is rapidly absorbed. At 6 hours, gastric decontamination won't prevent toxicity. Option 3. While monitoring is important, the level clearly indicates the need for treatment. Delaying NAC while monitoring allows continued hepatic damage from toxic metabolites. Option 4. Hemodialysis doesn't effectively remove acetaminophen and isn't indicated for acetaminophen toxicity. NAC antidote therapy is the standard of care. Clinique RN Test Day Tip: acetaminophen toxicity. Use nomogram for levels 4 to 24 hours post-ingestion. If the above treatment line or an unknown time of ingestion with a detectable level, give NAC immediately. Most effective less than 8 hours, but give up to 72 plus hours if hepatotoxicity is present. If you want more Nclex questions like this, like, subscribe, and hit the bell. Sign up for free with the link below. And don't forget, you're closer than you think. See you in the next one.